Hello everyone, I am going to talk about the subject entitled Helicobacter pylori uninfected gastric cancer. As you well know, H. pylori was identified by Dr. Warren and Dr. Marshall. It was reported that H. pylori is associated with various gastrointestinal disease. 40 years have passed since the discovery. The IARC cites H. pylori as a group 1 carcinogen for gastric cancer, as you know. Recently, H. pylori infection rate is decreasing in Japan in any age. Accordingly, number of H. pylori associated gastric cancer will decrease, while number of H. pylori uninfected gastric cancer will increase. Rate of H. pylori uninfected gastric cancer was reported to be 0.5 to 4%. We investigated endoscopic and clinical pathological findings of H. pylori uninfected gastric cancer in our hospital. Consecutive cases with H. pylori uninfected gastric cancers, which were resected endoscopically or surgically, in a hospital between January 2013 and May 2020 were included in the analysis. Primary endpoint was prevalence, endoscopic and clinical finding of H. pylori in uninfected gastric cancer. I am showing the result. The number of H. pylori uninfected gastric cancer was 43. The prevalence of H. pylori uninfected gastric cancer among all gastric cancer was only 2.3%. Regarding clinical pathological findings of H. pylori uninfected cancers, mean age was 60 years. There is no difference in gender. In macroscopic type, elevated type was common. Location tended to be upper part of the stomach, and depth of invasion was mainly mucus and submucosal. Lymphovascular invasion was detected only in 2 advanced gastric cancer cases. I'm going to show H. pylori uninfected advanced cancer as a gastric cardia. An advanced cancer of ulcerative expansive type is located at the gastric cardia. Both 2 advanced cancers were found at gastric cardia. Histopathological findings show well to poorly differentiated adenocarcinoma invading down the submucosa. I'm going to talk about H. pylori uninfected early gastric cancer. The number of early gastric cancer was 41. It's quite rare. We classified histological type first as differentiated type and undifferentiated type. In differentiated type, there are gastric phenotype and mixed gastric and intestinal phenotype. In differentiated type, very well differentiated adenocarcinoma with gastric phenotype such as foveolar type, fundic gland type, and fundic mucosa type were common. All undifferentiated type is signet ring cell carcinoma. Location was different depending upon the histological type. Differentiated carcinoma with gastric phenotype is located at fundic gland mucosa. Differentiated carcinoma with mixed phenotype is located at pyloric gland mucosa. All undifferentiated carcinoma is located at the border between fundic gland and pyloric gland mucosa, that is, the incisura. Macroscopic type is also different depending upon the histological differentiation. Differentiated type tended to show elevated type, and undifferentiated type showed flat or depressed type. Okay. This is an illustration showing localization and histological type of H. pylori uninfected early gastric cancer. In the gastric fundic gland mucosa, adenocarcinoma of fundic gland type, very well differentiated adenocarcinoma of foveolar type, and polyposis-associated adenocarcinoma are common. Signet ring cell carcinoma is limited to the border between the fundus gland and the pyloric gland mucosa. Well-differentiated adenocarcinoma of mixed phenotype is common in the pyloric gland mucosa. I would like to show some representative cases. First, very well-differentiated adenocarcinoma of foveolar type. Type 02A located at the fundus gland mucosa. By conventional white light endoscopy, a pale superficial elevated lesion is noted at the upper part of the gastric body. After the dye was sprayed, it is evident that this is a well-demarcated lesion with regular granular surface. When we observe with this lesion with magnifying endoscopy with narrowband imaging, it shows clear demarcation line and irregular microvascular plus irregular microsurface pattern, which meets the criteria of cancer. Histological finding of the resected specimen by ESG shows very well differentiated adenocarcinoma, which is similar to foveolar epithelium. I'm going to show another foveolar type. It is so-called raspberry-like appearance. It's quite unique region. By overview, a resident polypoid region is present beside the fundus gland polyp. By closer view, it shows raspberry-like appearance. After the dye was sprayed, the surface shows a granular pattern. Magnified endoscopic finding with NBI demonstrates irregular microvascular pattern plus irregular microsurface pattern with a demarcation line, which are compatible with early gastric cancer. Histological finding of ESG specimen shows very well differentiated adenocarcinoma quite resemble foveolar epithelium. Again, this is characteristic finding of very well differentiated adenocarcinoma of foveolar type showing so-called raspberry-like appearance. This is a newly identified gastric neoplasia by Japanese endoscopists. Next, very well differentiated adenocarcinoma of fundus gland type. This region is characterized very recently. At the gastric fundus, a pale slightly elevated region accompanied with superficial vascular dilatation. After the dye was sprayed, it shows smooth surface. By magnified endoscopic findings with NBI, it only shows regular microvascular pattern plus regular microsurface pattern without a demarcation line. So this type of lesion can't be diagnosed as cancer by magnifying endoscopy. Histological finding of ESG specimen shows that the surface is covered with normal epithelium, but in the middle part of the mucosa, there is neoplastic tissue which mimics fundus gland. Since the neoplasia is covered with normal epithelium, magnifying endoscopy is not useful for making a correct diagnosis. The conventional endoscopic finding of a pale superficial elevated lesion with vascular dilatation are only keys for detecting such a lesion. Please remember these findings. And don't forget to take a biopsy and write a message to the pathologist that you are suspecting fundus gland type adenocarcinoma. This type of neoplasia is reported by Japanese doctors. Next is also newly identified neoplasia quite recently. Adenocarcinoma of fundus gland mucosa type. As the gastric fundus, a pale, slightly reddened region accompanied with vascular dilatation is present. After the dye is sprayed, the surface shows a granular patterns. Magnified endoscopic findings with NBI shows a distinct demarcation line, as shown by arrow, and inside the demarcation line, irregular microvascular pattern plus irregular microsurface pattern are evident. we can make a diagnosis of cancer according to VS classification system. Histological findings show that in addition to neoplastic tissue, which mimics funding glands, surface epithelium is composed of cancerous tissue, which resemble foveolar epithelium. So this is defined as adenocarcinoma fundic mucosa type. Since the surface epithelium is composed of cancerous tissue, we can make a correct diagnosis of cancer by magnifying endoscopy. This neoplasia was first reported by us. I am moving on to the subject of mixed phenotype, which is detected at the antrum. I'm going to show a case. At the antrum, multiple slightly depressed reddened regions are present. Among them, this region is well demarcated. By the closer view, a pale depressed region is surrounded by reddened mucosa is present. Chromoendoscopy findings show a regular margin. Magnified endoscopic findings show irregular microvascular pattern plus irregular microsurface pattern with a demarcation line. Light blue crest is present at the edge of marginal crypt epithelium. This slide shows a mapping of cancer's extent on the ESG specimen. The size of the tumor cancer is 5 millimeters. I'm going to show histological finding of this specimen. In the black square, I am showing neoplastic part. In the green square, non-neoplasia. The neoplastic tissue demonstrates very low-grade superstructure and cellular atypia, which is compatible with very well-differentiated adenocarcinoma. When we investigated the background mucosa carefully, interestingly, intestinal metaplasia is present even in H. pylori uninfected stomach. The last, I'm showing signet ring cell carcinoma. This type is located at the border area between gastric fundic and pyloric gland mucosa. Okay. Can you detect the presence of the region? This is it. A minute pale region is detected at the patient, at the posterior wall of the gastric incisura. A closer view shows a well-demarcated flat pale region. Dye spraying method does not enhance the morphology of the region. By magnifying endoscopy with NVI, there is no demarcation line, and both microvascular and microsurface patterns represent regular patterns. So magnifying endoscopy is not useful for making a correct diagnosis. Histopathological finding of the resected specimen show signet ring cell carcinoma, which is measured as 2.5 millimeters. Since the carcinoma cells invade the middle part of the laminate propria mucosa without changing the surface epithelium and the subepithelial vessels, magnifying endoscopy cannot detect any specific changes for carcinoma. I'm going to show a very interesting case with signet ring cell carcinoma. I am showing the first endoscopic finding in a hospital. Can you detect the region? The arrow shows a flat pale region as the greater curvature of gastric antrum. At this time, the endoscopist does not think this is a carcinoma. 7 years later, the pale region becomes more distinct compared with the previous finding. After the dye was sprayed, it shows a slightly depressed region with an irregular margin. The endoscopic took one biopsy from this region. However, no malignant tissue was obtained. When we reviewed these endoscopic images, we noticed that the biopsy was taken from the distant part, so that can cause sampling error. 14 years later, the pale region was still present at the same part. The margin of the region becomes more irregular. 17 years later, after the first endoscopy, the pale region was still present at the same part. The endoscopic findings show a well-demarcated pale depressed region with irregular margins. These findings are characteristic for early gastric cancer of signature cell carcinoma. This is non-magnified endoscopic images with narrowband imaging. The histological finding confirmed signature cell carcinoma, and then we resected this region with ESD. The histological finding of the resected specimen shows signature cell carcinoma limited to the mucosa without lymph node metastasis, without lymph vascular invasion. All the resected margins are free from cancerous tissue. The maximal diameter of the region was 8 millimeters. When we reviewed endoscopic findings during 17 years, no remarkable changes identified. When we referred the paper, the previous report, this is the longest observation of signature cell carcinoma. Okay? So again, I am showing the characteristic of early gastric cancer in H. pylori and infected stomach. In the cardia, advanced cancer are present. In the funded gland mucosa, we need to detect elevated region of well-differentiated type. At the border, we need to detect flat, pale region of signature cell carcinoma. In the pyloric gland mucosa, we should detect very subtle region of well-differentiated carcinoma. If we are familiar with such characteristic finding depending upon the part of the stomach, we are able to detect early gastric cancer even in H. pylori and infected stomach. In conclusion, H. pylori and infected gastric cancer shows distinct characteristic clinical pathological findings depending upon the part of the stomach. Thank you for your kind attention.